Dun dun dun. Dun dun
All
dun.
right, we are on, and people are coming in.
What's
Mel
new in
Pearson was the first one in the virtual door.
Does he get a prize?
Congratulations. A
We need
virtual one.
prizes.
All
We
right. Chris Gipple, Dana Blalock. What's up, y'all? How are you
we like
guys?
we
Alina?
like timeliness here.
Yeah.
Promptness. It's already 8 o'clock where I'm from. This, you know, it's
Well,
late.
listen, man. I mean, in golf, there's a handicap on the East Coast. It's called a head start. Like everybody's got to start somewhere.
Yeah.
I'm messing around. All right, everybody. You know the drill. If you've been on our webinars before, if you have not, you're in for a treat tonight. We are going to bring you some great clinical content tonight. We're also going to do it in hopefully an entertaining fashion that we are not giving anyone sleep apnea on a DSM webinar. That's the goal here tonight. If you would, please verify that the chat works for me. If you'd put in where you are tuning in from, that would be awesome. I'd super appreciate that. Let us know. We got a couple people.
Oh,
North
God.
Carolina, Austin, Calgary, Gilbert, Arizona, Panama. Dr. Fernando, appreciate you tuning in, man. That's awesome. Sometimes he's the furthest away. Baltimore, Saratoga. All right. California, Oklahoma. I feel like I'm singing my kids' elementary song about the United States, like just naming off the states now. That's funny. All right. So Brad Sainsbury in San Diego. I think you're the closest to me so far. And
Welcome
Charles,
back,
you're in
Brad.
Kauai. Everybody's jealous now. Hey, you know what? It's 2 o'clock his time, Justin. Like, I don't know what to tell you.
2
Oh,
a.m.
no, actually three. I'm sorry, 3 p.m. They're 2 hours
Okay.
behind us. All right, y'all. So let me do this. I want to get out of the way here. It's a CE webinar. Y'all know how this goes. You got to stay on for the whole time and take detailed notes. I'm just messing. You got to stay on the whole time in order to get your CE. At the end of the time, we're going to put a link in the chat, followed by an email tomorrow. You can click that link, fill out a survey that takes you, I don't know, somewhere between 12 and 32 seconds. You fill out a couple of questions, get your CE, all that kind of good stuff. That's probably not why you're here. If you are, that's how you get it. Why you're probably here is to hear from this guy, not this guy, but that one from Tampa, Florida. He is talking about TMJ tonight. We have heard you loud and clear. Thank you all for registering and asking your questions. We've taken all of your questions, distilled them into a handful. Likewise, if you have questions tonight, I want to give you some directions. Please put them in the Q&A. If you have questions for Dr. Justin, we will stay here until your questions are answered. Best of our ability until about 6:15 Pacific, 9:15 Eastern. That's the timeline we got tonight. So we want to get to your questions. If you'd kindly stick them in the Q&A, we'd appreciate that. I will try to grab them in real time if possible and pepper Dr. Justin with those here. If you have technical issues, please put them in the chat, or if you're responding to his questions, that's where the chat is for, just like you did for where you're coming in from. We appreciate you guys. Let me introduce this guy and move us along here. Dr. Justin Elikofer hails from Evansville, Indiana, weighing in at, I'm just kidding. Now he started
More
off,
than I need to be.
yeah, working at Heartland of all places. Great place to cut your teeth and lots of teeth. Sorry, this is why I'm not here the whole night, right?
Yeah.
Anyway, yeah, this guy followed his dream to Florida, lives on the west side of Florida in Tampa. He worked in DSM only, in a DSM only practice. So he went from sedation dentistry to the real sleep dentistry and has done a couple thousand cases in his career. Lots of cases, lots of experience with TMJ issues. So he's the guy that's going to talk to us tonight. He now is currently the proud owner of a bustling GP practice while still doing sleep and TMD treatment in his practice. He's the guy that's going to talk to you tonight. Like I said, he's humble, slightly sarcastic, and occasionally funny. We're going to go with him tonight. So, Dr. Justin, I will pepper you with questions later, but
Yeah.
I want to get out of the way here, man.
Yeah, let's have some fun. Let's talk about the jaw joint. As Michael has said, I've treated a lot of patients over the years, and a lot of our patients have some sort of TMD or TMJ dysfunction. And so the good news is we're still treating nearly all of those patients. And so that's really what we're gonna talk about today. As far as, of course, we always want to thank our sponsors here. We have Kettenbach Dental, Nearman, Sleep Apnea Leads, ProSomnus, and United Credit. They obviously help us put this webinar together. And so it's always important. They're there to help you guys in whatever way you need. Lean on these. I always tell our participants, really lean on these vendors. They want your business. They want you here. And guess what? They want you doing more and more sleep. So they're going to figure out a way to get you doing more and more. And so my goal today is to really talk to you about the anatomy of the TMJ and the movement. In order for us to treat these patients, we have to have a solid understanding of what the jaw joint is and what it's doing. And so in order to do that, we need to examine it. So we'll talk about the clinical implications of the exam, what we're looking for, and why we look for it. And that will also help us, again, understand the movement and the anatomy, and then help us evaluate the signs and symptoms and co-managing of this disorder. The number one thing that myself, the AADSM, want you to understand is that TMD is not a contraindication for oral appliance therapy. It's just not. It is important that we document the presence of it or it not being there, but it's not a contraindication. And so we should be treating these patients, and we have to discuss this with our physician friends and with our patients alike, because when we consult with our patients, we are going to want to educate them a little bit more about their specific standing. And so to really first understand the TMJ itself, I think it's important to start out at the ligament level. So with our TMJ, we have four basic ligaments that's going to limit the movement forwards, backward, left, and right of the jaw joint. Just like all of our other joints and our shoulders and our knees and our ankles, we have ligaments that limit the movement. Here in the TMJ, the big one is our fibrous capsule. That's going to be important. The capsule in of itself can get inflamed and can cause discomfort. So pulling on these structures can actually cause strain, just like we can strain other ligaments in our body. And so it's important to understand that when a patient is coming to you and saying, hey, I'm having a little discomfort here or there, being able to localize that, whether it's pinpoint or generalized, we have to have in the back of our mind where these ligaments are attaching. I've actually had patients who've been able to really localize their pain here to the lingual of the mandible, or the lingula rather, of the mandible. And so we can kind of tell how we can adjust our devices with that. You see the stylomandibular ligament, again, preventing that jaw from protruding. Our patients who have, some of my patients have -15, +15. They have a 25 millimeter range of motion. Some of them only have 8 or 6. And so that stylomandibular ligament is one of those main ligaments that's going to limit that. And again, we have a lateral ligament that prevents the jaw from dislocating sideways, and the fibrous capsule, as I said earlier. When we kind of zoom in on that capsule, it's important to see that it's, again, encapsulated, right? It's the joint capsule. And again, this is an area of the body in and of itself. Inside this capsule is the synovial fluid, the lubricant for our jaw joint, as well as a very, very important structure called the articular disc. And a lot of us know all this from dental school already, but the articular disc is what rotates on the condyle, and it's actually going to be attached to the condyle with a mesial and a lateral ligament as well. And so why is that important? It's important to understand that just these structures in of itself can become inflamed and irritated overall. So it's not always the joint itself. Sometimes it's the ligaments and the inside of that joint. And as I said, this disc, the condyle and of itself is also going to rotate and move. And so not only do we need to know the ligaments, we also need to understand the muscles that pull and move our jaw joint, as these muscles can also become sensitive and sensitive to touch or even sore in the mornings. And so again, as we've all learned in dental school, a lot of the major muscles are the temporalis, the medial pterygoid, the lateral pterygoid, and the masseter muscle. All of these muscles move the jaw joint in one way or another. The temporalis, medial pterygoid, and masseter are going to move your jaw up and down. The lateral pterygoid is going to be responsible for really protruding that muscle or that joint forward. What we also find is when we zoom in even more again on the disc, we can see that lateral pterygoid is attached to the disc of the joint. And so as we move our jaws forwards and backwards, that disc is going to move. So when our jaw is closed, TMJ is closed, that articular disc that we've seen in a couple other diagrams sits on top of the head of the condyle. As your jaw opens up a little, usually about 10 to 12 millimeters, all that we get is rotation of this condyle here. As we continue to open up more and more, our body begins to recruit muscle fibers of our lateral pterygoid, which not only pull the condyle forward, it pulls the articular disc forward. And this is going to be very important because whenever we have patients who have TMD, they have what we call internal derangements. And an internal derangement is when this articular disc isn't functioning in the way or the manner that we really need to. And so we're going to talk about that in a little bit. But again, this is kind of a normal jaw, a normal closed position where the articular disc is going to sit on top of the condyle. It's going to be held in place again by the capsular ligament here on the posterior side. And that's going to prevent us from pulling that articular disc all the way forward and out of place. When we look at the articular disc itself, we remember that the articular disc itself is avascular, right? There's no blood vessels in the disc. But interestingly, there is blood, there are blood vessels, there are nerve endings in what we call the retrodiscal tissue. And so when we looked at the joint capsule earlier, and I said the joint capsule in and of itself can get inflamed. Also, this retrodiscal tissue, because it can change, and because we are putting different forces on the retrodiscal tissue, it can become irritated, or it can even swell and can become painful, especially for patients in the morning. So a lot of our patients, if you really, really ask them a lot of questions about when does it hurt or when does it not hurt, a lot of our patients who have quote unquote TMD or popping and clicking of the joint, 90% of the time is a retrodiscal issue. So we're likely relieving this tissue in some way, shape, or form. That tissue is then inflamed or enlarged. And when we take that patient out of their device in the morning, and we've been holding their jaw in a more forward open position, and we take that device out and we close their jaw, again, 90% of the time, when we put this condyle back in our posterior superior position, we're going to be pushing on this retrodiscal tissue, which is going to be a different size and shape. So this is something very, very big to understand, something very easy to kind of explain to your patient, that when we open and close our mouths, our jaws move forward and our disc moves forward. And that relieves a lot of the pressure on our retrodiscal tissue, the tissue in the jaw joint that can actually kind of become intruded with more fluids, blood in itself. I don't like to say that word. I usually say fluids, but it can swell up. And so in the mornings, we're going to want to slowly kind of squeeze that back and let that rest and reposition that jaw. I know a lot of us on here are using some sort of repositioner. So moving that jaw backwards and doing it in a very comfortable, seamless, easy way that is again comfortable for the patient. So really important slide here, just to kind of understand and to really show you more about these internal derangements. This video is an old video. It's an oldie, but a goodie, as they say. And really is, in my education, really gave me the best really understanding of what a normal jaw joint looks like. I'm also going to show you what a reducing or a popping jaw looks like. And so I think when we understand and we can see these videos of what normal is, what a popping joint is, and what a joint that is dysfunctional but not popping, what those look like, it really helps us have that conversation with the patient on what to do in ways that we're going to help them co-manage. Again, we want to be very positive. Mr. Patient, we can co-manage this dysfunction. And we have a high success of doing that. So first, here is this normal TMJ.
This is a normal temporomandibular joint. The disc is biconcave and it's located in a superior position. The central thin part of the disc is consistently lying in between the condyle and tubercle.
So you can see here is the disc in and of itself, avascular, very fibrous, very lubricated. On the back,
during opening, there is rotation in the lower compartment.
This retrodiscal tissue. And think about our patients. Think about our patients and their appliances. This is where their jaw is sitting at nighttime, right? Probably a little bit further backwards. Really depends on your protrusion. Have you extended these patients out as far as they could go? It's probably going to look more forward like this. And so it's easy to understand with this video how much that this tissue can expand during the night, during the 8 hours, as well as other tissues or other clavicular fluids coming into this posterior space. So
translation in the upper compartment.
So what about our patients that have popping or clicking? So popping and clicking by definition is what we call reducing a joint. And so if your shoulder goes out of place and you pop it back into place, they call that reducing the shoulder. So the same thing we see with jaw joints is jaws can pop and click. And the reason that our patients' jaws are popping and clicking, usually when they open, is that the disc itself, we just saw the normal disc that's moving cleanly with the condyle. A popping disc results because actually that muscle, remember that lateral pterygoid that we just saw that's attached to the disc, is overstimulated or overactivated, and that's actually pulling that disc in a more forward position so that the jaw joint is resting more so at the junction of that retrodiscal tissue and the disc itself. And so you'll see in this video, you'll see a pretty abrupt movement of the disc. And when you see that, that is that popping. That is the disc popping on to the appropriate place, on the condyle. And so this is again the anterior disc. It's pulled forward.
In this joint, the disc is anteriorly displaced.
You're gonna see that click, really abrupt movement of the jaw multiple times.
And
then, so you'll see too, when they close their mouth, it clicked back off. That's called a reciprocal click. You usually don't hear those, but sometimes you can when you palpate the patient's jaw and you have them open and close. Sometimes you can hear that, sometimes you can't. It's usually easier to hear that first opening click.
On opening with a click. These joints demonstrate reciprocal clicking, which implies clicking during opening, followed by clicking during closing.
So I think this video does a really good job at showing the physicians and showing clinicians that actually, if by chance we can open these patients up, we can move their jaw forwards and actually get them to click into our devices, we could understand that the articular disc in of itself would actually be healthier and would be more protected, right? There would be less impingement on that retrodiscal tissue. And so again, this is a great video to really understand and see that movement overall.
The disc is here again anteriorly displaced.
This is all that retrodiscal tissue, right? And so, and you can understand that whenever we put a patient in appliance and we take this pressure away, and there's blood vessels in there, and extracurricular fluids can go into that space, that could cause some sort of change. I like to use the word sensation when I talk to my patients. I don't like to say discomfort. I like to say there's going to be a sensation. You're going to know it's there, and this is what it feels like. I don't really like to use the discomfort word. So what else can happen? Well, what if that disc doesn't pop onto place? How do we know that? These patients who the disc just stays in front and you're just translocating on that retrodiscal tissue, making it thinner and thinner because it's not fibrous, those patients are going to usually have some sort of limited opening. So when you measure their mouth and you have them open real wide, they're usually going to have some sort of limited opening. These are the patients that from a dental standpoint, we really don't like. Hard to, you're not going to want to cut a crown on a non-reducing anterior displaced disc on a second molar. So that's not going to be a fun day. But here you're going to see that this disc is, in this video, it's actually going to stay forward for us. So here's the disc.
The next joint demonstrates anterior disc displacement without reduction, which implies that the disc is consistently lying anterior to the condyle. During all mandibular movements, the disc is lying anterior.
And usually this is why our patients have limited openings. They're only so far that we can get before it gets jammed up. And remember, our ligament is attached, the retrodiscal tissue is attached to the posterior fossa here. And so it's going to limit our movement, and the disc itself is going to impinge and prevent that jaw condyle from going really as forward as it can. These videos are on YouTube for sure, easy to review. And if you just type in non-reducing,
and as maximum opening,
anterior dislocate,
the disc is folding,
reducing, you should be able to find them pretty
folding
easily.
downwards.
If you need them, email Michael or Chad or myself. So
I'll go ahead and put the original YouTube video in the link in the chat so you guys can copy it.
I got you. Perfect.
Thanks,
thank you, Michael. I'm glad you're here.
I'm glad. I think everybody else is more glad that you're here. Since I'm on, I do have a question for you.
Yes.
You started off saying that TMD is not a contraindication for oral appliance therapy.
Correct.
Why do so many people feel like it is?
I think it's because they're not educated. I don't know. They didn't go to AADSM diplomate school. They haven't done it. I think can't find the word, but we're so concerned, and when we see a TMD patient, we're like, oh, your joint is so fragile. We don't want to do anything to mess it up. But what I'm going to talk about later is, well, why wouldn't we be doing anything to stabilize it? And why wouldn't we do anything to protect it? We'll talk here a little bit later that, we're going to make splints for these patients, right? Let's assume they don't have sleep apnea. What are you going to do for a TMJ patient? They're going to make them a splint. So why do they think that? I also say this, we've gotten a lot better at oral appliance therapy. And I think before I was around, I don't think we started off as conservatively as we probably should have been, maybe in the early stages of oral appliance therapy. And I see it today still with some dentists. I had a patient this morning who has bite changes, and he was held out at his maximum pretty quickly. And so absolutely, we can induce TMD in our patients if we're not conservative enough and we don't let them acclimate to these procedures. So that's my best guess, is that prior to 2016, 2006, I think these practitioners, maybe that'd be my best guess,
Sure.
we're maybe holding those patients out too far too quickly.
Yeah. And I would add, it's fear. I mean, if we're all being honest, I'll be the one to speak for everybody else who doesn't have a face tonight that's willing to own this. Like, at the end of the day, chronic facial pain patients are kind of dangerous for the practice. It's a little bit scary to deal with somebody who's in chronic pain, limited opening, all of that kind of stuff. But, you've got a lot of clinical confidence in this, Justin, because you've done so many cases. You've seen all the different tweaks and done a lot of the different things. So I just want to convey that to everybody else. Like, if you're afraid of taking on these patients, you're still in a good spot. Walk with caution and listen to what he's talking about. I got lots more questions, but I'm going to hold those until later. I just didn't want to skip that from earlier.
Yeah, I think that, the most important thing is the exam, right? We want to examine these patients. And really the reason this exam is important is so that we can diagnose the TMJ before we get started. Again, we're going to ask the patient, do you have pain? Is it chronic? Is it acute? When is it? Is it hurt whenever I push on that? Is there any sort of pre-existing dysfunction? Because if we're going to put a patient in an appliance and their jaw is not in correct function, we can let them know, hey, we're going to manage that. But we also know, like I said earlier, if we have someone's popping and clicking and we move their jaw forward and we actually let that retrodiscal tissue expand, those patients are going to be more likely to experience discomfort in the mornings. And we want to stay in front of that. We want to set that expectation. So the most important thing we can do is really diagnose and have a discussion with these patients early on, saying, hey, Mr. Patient, we know you have sleep apnea. It looks like during our exam, you have some popping and clicking, and your jaw joint likely isn't functioning the way it should. Good news is we can co-manage sleep apnea and TMD together. But we do also know that patients who do have dysfunction that's pre-existing will have a higher likely incident of transient pain. So I like to use that word transient. I let them know that most of our patients do experience, if you do a lot of these, most of your patients are going to experience some sort of transient discomfort that's going to last 2 to 3 days, and that's going to get better and better with increased compliance and increased wear time. We know that. And those are our normal functioning jaw joints. We do want to let these patients know, hey, there's a dysfunction here. You're more likely to have those issues. And this is how I'm going to tell you later. I'm going to tell you how we mitigate those factors. So again, does it matter? No, there's a lot of evidence-based research that supports that absolutely. Using a mandibular advancement device, we're putting force on your tooth, on your muscle, on your joint. If we don't, do it cautiously and conservatively, sure, we can induce a TMD in a small amount of patients. But nevertheless, usually this is transient. Our devices are removable, so worst comes to worst, we can have the patient just not wear the device for a while. But we know that the mads themselves can be used to co-manage. And there's more than just one research out there. Again, our goal when we do see these patients, when we're doing our exams, the point is to diagnose them so that we can understand that we need to stabilize the jaw. We want to prevent that posterior superior positioning, and we want to hold that articular disc in its correct physiological position. Also, I always talk to patients who have popping and clicking. Those patients are going to have a higher incidences of bite changes. So let's say we give them a sleep appliance and we improve their TMD condition. And now it doesn't anteriorly reduce when they close down. Well, there's going to be more of a space in their posterior teeth. So for these patients, we need to let them know, hey, there is a chance, and it doesn't happen that often, there is a chance we recapture this disc and get it back to where it really needs to. We know if we do that, that it can change the way that our teeth fit together. And if that happens, we'll have to approach that when it gets here. But I just want you to know that that can happen. It's a good thing because we're helping your TMJ, but it can cause some other issues that we want to kind of focus on. Again, it's all about managing expectation, managing outcomes with these patients. I've met with a lot of TMJ doctors here locally in St. Pete, and more of them are saying we need to treat the jaw joint just like we would an injured knee. So these jaw joints are injured, a knee is injured, we're going to splint it and we're going to brace it so that we allow it to move. We never want to immobilize a joint. That's only going to cause stiffening. That's not a good way to treat TMD or knee pain, but we do want to brace it. We want to limit the movement. And so, like I said, we work with a lot of patients. I have general dental patients, and we refer to a TMJ doc. But guess what? I think it all really started to click once I was in this general practice here recently, and I had a patient who had some pretty significant TMD, not even wearing a device. So these excerpts are from a patient that does not have a sleep apnea device, but she was having some pretty severe in my chair crying. I think we've all been there. We've had a patient like that. But it all kind of clicked to me whenever I got the response back from that doctor. And his number one treatment for her was just go home and rest and reduce the function of the joint, right? Let's not immobilize it, but let's just minimize the pressure on it and kind of let it calm down. Of course, you always need some sort of therapy. And then the second thing that he recommended was a splint. And he gave this long, you can see it's a paragraph of design. What the design of the splint should be converted to allow the teeth to touch simultaneously in front and back, no matter how the lower jaw is positioned. Well, that sounds an awful lot like a dorsal device or a Herbst device. The amount of compression or loading against the damage of the joint will then be minimized. And so if this is how we're treating a TMD patient without an oral appliance, why can't we modify our custom-made oral appliances to just mimic these devices? And it's super, super easy. And so we really, again, after the exam, just need to stop and think. Our patients who have pain, chronic pain, crepitus, that grinding when you feel it on there, need two things. They need posterior and lateral support. We want to minimize the pressure on those jaw joints, and we want to minimize the ability of them to move laterally, left and right, because that's gonna actually give that jaw joint a little ability to rest. Here you can see, just circling here. Again, the easiest way to do this with someone who, again, only thinking joint here and not muscle by any means. If we're thinking joint only, we want to have full contact support all the way around, entire left, right, lateral movement, and we want that posterior support. Every once in a while, we'll have a patient who maybe we're concerned of their joint as well as their muscle. Maybe we think their muscle is causing some of their joint pain. These are when devices like the TAP or something with a discluder where we can add that posterior contact as well. So again, for patients who are we're only worried about their joint, they don't have bilateral masseter hypertrophy, they don't have any temporalis pain in the morning or anything like that. We really just want to focus on having full coverage support all the way around with lateral support. If they are having some sort of muscle, we may consider doing something like this TAP that has the posterior support and a bit of a discluder element to it as well. Hey, Michael.
Hey, so on this, since you mentioned appliances that you've used in your hands, the TAP obviously has the anterior discluder kind of built into that device. But other devices, what devices have you used with success adding that to it? We're essentially adding an NTI to a sleep appliance. NTI by itself is the anterior discluder for TMD independently in some patients, but which appliances have you actually done in your hands that you've seen work in certain patients' mouths? And which ones would you not lean towards if you were dealing with this kind of combo treatment?
In specific, like which ones have I used anterior discluders with?
Yeah.
So all the big names out there, Prosomnus, I delivered a Prosomnus today with a discluder on it, no posterior support. This guy is just a big grinder, not a joint issue at all, no popping and clicking. You can add these to Somnomed dorsals. You can see a picture here. You can add discluders to the Avance. A lot of these companies allow you to modify these devices pretty easily. So I don't know. I feel like I've probably done all of them at least once. They're all similar, right? I think the message is if you're really worried about someone's painful jaw and they're just, they're doing pinpoint, we can get into the weeds of this, but for an hour lecture, if they're having pinpoint pain in their jaw, we want full support, full occlusal coverage, full support all the way around. If we think their muscles, the temporalis, the masseter, medial-pterygoid, we want to get a discluder involved in some way, shape, or form, because the muscles of itself can be pulling on that joint capsule, can be pulling on that articular disc and causing a lot of that inflammation for our patients. So the question becomes, well, if we do have a patient sitting in our chair, is it muscle or is it joint? How do we know? Well, there's a bite test that basically tells us if I bite down, if I give them a tongue depressor and I say, hey, bite down on this on your right side, and we get pain that's on the contralateral side, what's happening is the jaw is being forced up into the area on the contralateral side. So that tells us it's joint. So have a patient bite down on a tongue depressor. Which side hurts, the tongue depressor side or the joint side? If the joint side hurts, then it's likely a joint issue for that patient. And vice versa, if they bite down on the right side and they say, doc, this side hurts when I do that, that's likely a muscle side. And so we're going to talk about a case that I had here, and the patient came back, ipsilateral pain on the right side, or it's actually on his left side. On the left side. And so I kept thinking, I was like, I think it's muscle, but I kept thinking it was my device. And so what we come to find out is really it was a bruxing issue that we were able to stop with a discluder. So we'll talk a little bit about that. So even every once in a while there, patients will get by me that, I really don't anticipate needing a discluder. And then all of a sudden we get them in an appliance, and we'll talk a little bit about that. So again, bite stick, same side hurts, muscle. If the opposite side hurts, then it's a joint issue. And so you can do that on both sides. So getting back to Michael's question about TMD, again, why do some people think that way? I'm not sure. There's, multiple papers that suggest that oral appliances can kind of co-manage these overall. And so, it's important that we get the message out there to other doctors to stop that funnel of information to the physicians, because we absolutely have physicians that don't refer to us for some reason or another. Oh, well, you're going to cause TMD. Well, you can, absolutely. But, send it to somebody who's been doing a lot of them and should be fine.
Justin, quick pause. The whole, it's not a contraindication. You've been doing medical billing for a long time. This is not a medical billing webinar, but we've got a question specifically related to TMD on this.
Okay.
Dr. Michael Valag says in the Q&A, he's got some insurance companies that the billers are saying that you have to sign this document that says their TMJ is under control. There are no ongoing TMJ issues, so that the insurance doesn't deny the claim.
Right.
So can you speak to that? Because I know you handle this a lot. I don't want to get stuck in the weeds on insurance stuff, but how do you balance that with treating both? Which one are you managing? All that stuff.
Yeah. So I'm not a medical biller. I don't know if we can stop the recording or here or anything like that. But I believe the verbiage that we use is the patient doesn't have acute. I think the key word is acute. I could be wrong on that. And I don't want to go into too much of that. But as long as it's being managed, I feel super comfortable doing these appliances. And when's the last time you let insurance tell you what to do or what was right for the patient? The insurance doesn't always know best, for sure. But I think the word that I see a lot in my medical billing is acute. And so that's my answer to that.
Thanks, man.
Yeah. So this is my 46-year-old male patient, and had a history of snoring, excessive daytime sleepiness, and he's obese. Had morning headaches. I really didn't. He didn't desaturate a lot, and looking back, I never probably asked him the right questions. Maybe he's having temporalis pain in that, and so morning headaches. Sleep study is pretty basic, 11.3. I actually put him in a Serena Sleep Elevate, and his range of motion was -6 +6. So I set him at like -1, pretty simple case, and he didn't have any problems. He's going to say in this video that he had some problems pretty early on, but my document shows that he didn't have any problems the first couple weeks. It's when we advanced him that he started to have weak. But I think for clinicians that maybe don't hear what patients are saying, this is what your patients are going to say. And this is just one case. I mean, like I said, I can get in the weeds with this. We've done a lot of different cases. Things present so many different ways. But this is Sean here, pretty cool guy. He's a pharmacist. Sean here. Sean, we've been working with you for about 6 months. Tell us a little bit about your story as far as getting the oral appliance, any sort of issues that you have. See if I can skip this.
I had my sleep device, and pretty much immediately I started having this jaw pain.
It was not immediately. So, first, another key story here is don't let, your patients aren't always the best reporters.
Yeah, with it, more like muscle pain. Wake up and it would take hours to even remotely go away, and it was getting me to a point, and I would come in and we make adjustments, come in, make adjustments, come in, make adjustments over the months, but it was getting me to a point where I just did not want to wear it because of the jaw pain. And I know we tried steroid dose pack to help with that, and it pretty much did nothing.
Yeah. So that's a great little learning, again, looking back on this, we can always improve it ourselves. So he came in and his jaw was sore. It was fine the first couple days. So I really didn't think muscle. It was fine the first couple weeks, and then we protruded him. So I was thinking, oh man, it must be the protrusion that's causing this. And so of course I try to adjust the device. Usually ipsilateral pain on the same side is due from probably a capsulitis. Like I said, that retrodiscal tissue. This pain was lingering for a handful of hours on these days. So I really wasn't thinking, dull ache, muscle pain for him. So we tried what, right? Capsulitis, inflammation of the capsule. So I said, hey, let's try a steroid. Well, it didn't work. That should have been my first clue to like say, hey, this is muscle, right? We gave him something to decrease the inflammation of the joint, and it didn't help him. I also tried after that, essentially I tried some muscle relaxers. Those did help. And so as soon as we knew that, it kind of transitioned us where we wanted. So
we moved on to muscle relaxant. And so in trying them muscle relaxant, it would work if I took it prior to bedtime. But then I did not want to be in a situation in which I'm dependent on pills to make the device more comfortable. So that was getting discouraging. So again, it led me to stop using it because it's just not convenient and comfortable to do. Yeah. Which then.
So essentially what we did after that, I'm going to skip ahead here. I kind of ask him at the end, I say, tell me about the pain. This is what your patients are going to be saying. And this is why it can be hard, because when he talks here, let's see, get this to stop where I want.
So it was here.
So I just asked him, I said, can you show me exactly where this like started to hurt? Like what did you feel?
From your perspective, can you describe, when you say jaw pain, that can mean a lot of different things to a lot of different providers. Can you be more specific on the location and what your perception of that was?
Yeah, so it was here, right? It was here.
So the first thing you'll notice is he say here, generalized. So generalized is going to mean muscle.
Here, and when I would wake up, it was so tight, like just really tight and uncomfortable, that I would have to go like just for a long period of time just to get back to some like normalness with it. It was frustrating because.
So yeah. So what do we do? Like I said, I figured out, after I tried a lot of different things, I said, let's get him in something that hits more on the front. Here's his patient timeline again. In June, we delivered it. No negative side effects in July. But then all of a sudden we reduced his snoring. He was happy. We protruded him 1 millimeter, started having all this pain. He actually went through this bout of vertigo, all sorts of different stuff. We got that to resolve. We've kept him here at baseline here. But then we put him in a cheap, simple solution of a snore hook. I said, let me just get you in one of these. We're going to prevent your back teeth from touching, and we're going to reduce that. And so now he's happy with it. He loves it. I said, once you love it, I'm going to take good care of you. We're going to get him in a permanent tap device here soon. So again, his Flexerol improved his symptoms. So he was doing better. And again, so we gave you some medication that reduces your muscle activation. You felt a little bit better. So even more reason to do the right thing and get him a secondary device. Ideally, you stay in front of these. Cases, and you start off with this right away. In this case, I didn't, but it just goes to show you that you just need to be able to manage and understand the jaw, understand the muscles and the ligaments and the joint space. And if you just kind of stop and think critically about what's going on, you can usually find a resolution for these patients. So this wasn't a joint patient, but a muscle patient in particular. Chad, Michael?
I cannot help but be punny here. I can't help but appreciate the fact that your pharmacist patient immediately goes to, I don't want to be dependent on low-grade muscle relaxers.
Yeah.
I agree. Like holistically, I agree, but it's just a little funny for me. Sorry.
Yeah.
Maybe that's Tuesday evening humor. I don't know.
Yep.
Okay.
So let's open up
Remind-
some. So everybody's got
Go
some
ahead.
questions. This is the
Yep.
fun part. Hopefully that helps you guys. Kind of again, your first thing, you just need to understand what the jaw is doing, and when the patient's in your chair, what the dysfunction is, so that you can let them know, hey, you don't have a perfect jaw joint right now, and we're going to try to co-manage that for you. And this is how we do that. And these are a few of the different devices that we use for that. All right, Q&A.
Yeah, I love how you consistently, like, man, every time you teach with us, I love how you just talk to patients about we are co-managing this. I would say for the audience, every one of you that's treating patients with oral appliances for OSA, you're treating TMD, knowing how to talk to your patients and help them understand that you are co-managing this treatment together. They have to be a willing participant. They're not just sitting on the sideline waiting for you to do something else. Anyway, I know it's a soft skills and that's not our main webinar tonight, but that is a take home if you guys are taking notes tonight. Okay, I've got a bunch of questions that we pulled in from the questions you all asked when people registered, but you guys showed up tonight. So I'm going to prioritize anything that you put either in the chat or actually, please put in the Q&A. That really helps us out. If you got a question, Q&A, applause and love and all of that stuff for Justin, you can put that in the chat. Okay.
Like talking
Yeah.
about my hair. Thanks, Brian.
Oh yeah, somebody said your hair was on point. I was like, at first I was like, is it his or mine? It's for sure his. Okay. We already sent the link for the original video in there. So first question in the Q&A, can we induce vertigo with an oral appliance? So you just switched to fear, man. Talk about that.
Yeah, you know, there are some, I don't think I think the jury's still out on there. I think there's been a couple of evidence-based papers that have supported that idea, but there's also papers that don't support that. So I'm not a ask your ear, nose, and throat doctor. You know what that looks like. You know, there are some inner parts of the inner ear that are pretty close to that space. And my understanding, if I had a knife to my throat right now, would be that the inflammation of that joint, you know, can start to press on that area, and you know, inflammatory factors, you know, can contribute likely to that. His vertigo is interesting. It wasn't like onset immediately. So it was later, so which was interesting, and it went away. So, and he's in a snore. He hasn't had vertigo since. So I don't know that I wouldn't say that it induces it. I don't talk.
That was actually another question, man. I don't want to interrupt your train of thought. You said, you started to say it. Was the snore hook his final appliance? Is that what he's still in today? Or did you check it out later?
Well, now that I know something anterior to excluder helps here, I ordered a tap. I ordered a tap 3.
Cool.
So he's got a permanent tap.
Got it.
I don't.
Okay. So I'm gonna go with another question. If my patient has jaw pain before oral appliance, so you did the bite test. If it's on the side, it's muscle. If it's on the opposite side, it's joint. So the question is, if my patient has jaw pain before I deliver oral appliance therapy, how can I mitigate the risk of making it worse? And how does this change, like for you, Justin, how does this change your appliance selection?
Yeah. So again, it's all about the patient comes in, they have joint pain. So we've decided it's joint. Is that what I just heard? So
no, they just have jaw pain, generalized jaw pain. So you do your test, but walk us through your decision making.
Yeah. So I'm going to do my test and I'm going to try to get an idea of what I think it is. Is it joint or muscle? But I'm going to have a simple conversation. This patient has chronic jaw joint pain. They've likely tried some sort of mouth guard, right? I mean, God willing, somebody at some point has told them, hey, maybe a mouth guard will help. So I'll question them a lot about, well, have you ever worn a mouth guard? You know, what did that do for you? You know, did you have any issues with it? Did you like it? Did you hate it? And so essentially, after I interview the patient, I'll fabricate a device that helps mimic if that was a positive experience.
Yep.
If that was a positive experience, then absolutely, we can mimic it. If it was a negative experience, if they say, well, yeah, I just tried to wear this mouth guard. And it hurt and it didn't help.
Yep.
You know, I'm gonna tell them, hey, you have sleep apnea. Have we looked at our other options of treatment? Because, you know, if the TMD appliance that you had didn't help and maybe worsened, which I don't hear that very often. But let's talk in the what ifs here. You know, yeah, maybe my appliance doesn't help. We really got to get to the root cause of what's causing the joint dysfunction. Is it the joint? Is it the grinding? You know, holding these patients in a more forward position can be more comfortable for these patients. Have they ever tried anything like that? And so that's my answer.
Cool. I love it. Switching gears a little bit. Now you're post-delivery. So you delivered the appliance, you're protruding it. Person says, I've done a lot of these over the years. I've delivered a lot of OATs over the years. Some patients have jaw pain after protruding them forward. What are you currently doing to alleviate this? I'm guessing other than just pulling them back from that furthest protruded spot. Different techniques if you have bilateral or unilateral pain.
So
OAT delivery.
Yep. Yeah, so I've given the patient a device and now all of a sudden they're having pain. You know, if it's bilateral, so we talked to it's early on, we talked about the ligaments, right? So we can be straining. Everybody's ligaments are different too. And so sometimes we really need to slow down titration. I mean, that's the number one thing I do first is I say, okay, back up. You know, maybe we can't titrate them like most of our patients. That's the first thing. If it's bilateral, I feel most of the time it's a protrusion, too quick, too fast, you know, setting them backwards. If it's unilateral, again, most of the time it's the device itself contacting. So if it's unilateral, my first go-to, and even in that last patient, was to really just adjust the side of the device, adjust it down so that it doesn't hit as hard and there's not as much trauma on that side. And we can usually get that to go down. So if it's bilateral, you're probably protruding them too quickly, too fast. And essentially we want to get them back to a position where they're comfortable. And if we get, you know, super concerned that we don't want to try it again, you know, maybe we skip to a home sleep study sooner rather than later for these patients. Hey, let's just see where we're at. You know, every time we try, I've had that patient before, right? All right, well, let's step you back to baseline. Let's get you comfortable again. Okay, everything's gone away. All right, let's try to move you out again. Oh, I moved you 2 millimeters and you're miserable again. For those patients, we say, hey, let's get you back to baseline and then let's send you for a sleep study.
Yep. Cool.
Yeah.
All right. Different track. If clicking and popping is not necessarily a true TMD, like a dysfunction problem, how do I know when I'm dealing with true TMD versus muscle pain or early on TMJ disorders? How do you know if it's actually degenerative disease? I think is what the question's trying to get at.
Yeah. So if it's degenerative, you're going to see that on your like really bad. And I will say those are the patients that we don't put devices in. I think is probably a good way to answer that question is when you take a pano and their condyles don't look right, you know, you probably want to be careful on those patients. I'm not putting patients that have a significant degenerative you know, condylar dysplasia into these dental devices because yeah, usually you're just going to ask for some discomfort and some pain there.
Cool. This is an easy segue into the next question. Red light, yellow light, green light. In your consult, what's a red light? You're not treating this patient, you're referring them out. What's a caution? Yellow light, I'm going to proceed with different direction versus a green light, you'll just move forward.
Yeah. So red light, I just said like chronic pain, you know, you got a panel on this patient and everything just looks wicked. I'm probably not gonna touch that patient. And then, I mean, green light is a asymptomatic patient that doesn't know anything that's there. You just feel it, right? So not something that a patient notices, but you notice. That's definitely a green light. And then the yellow light would be something where the patient is uncomfortable, knows it exists, has signs, has symptoms, and it's also something you're observing. I think it's, again, we got to get back to, we talk about like dental and medical, you know, procedures in and of themselves have risk and benefits, right? The risk of not doing anything has its own risk. And so we have to be able to talk to the patient about that. Okay, patient, you have 28 apneas per hour, and you have popping and clicking in your pain and your jaw. You've tried CPAP, it's not an option, and your BMI is 38. So you have two options. One, we can try this. We know we have a higher likelihood of having some symptoms, post-delivery. But what are we going to do? Not do anything? I mean, that's an option, patient. My job here is to tell you what I see. I see that your jaw joint's not perfect. I see that your sleep apnea is not being treated. We can try to co-manage this, but understand, we don't hit a home run on every patient. In medicine, there's a lot of gray. Your HbA1c is not always 6.5, right? Sometimes it's 6.8, sometimes it's 7.5, and sometimes 7.5 is really good for some patients. And so just being able to have the education and the wherewithal to have that conversation to say, hey, we can attempt to co-manage this. Of course, we're going to have some issues that can arise. We're ready for those. And guess what? These devices are reversible. I have never, ever, ever caused any sort of permanent TMJ dysfunction to anybody. If we can't figure it out, if we can't make modifications to our device to help co-manage these, then we let our referrals know, hey, this device isn't working out. We need to find another solution. It's reversible. We don't have to wear it, but it does help to have the discussion with that patient prior to say, hey, we're at a higher risk of having complications here. Your jaw's not perfect. Okay. But neither is your sleep. And so we'll try to work on both of that, but understand, this may not, we may have issues that we can't overcome.
Yep. Good stuff, man. Okay. For those of you that are time clock watchers, your time has come for your CE certificate. We're going to put the link in the chat. We have two courses for you guys if you want to look at them. If you liked this tonight and you want more clinical insight on delivering appliances, contraindications, how to deal with all of this stuff, really sitting in the weeds with Dr. Justin and our team, we've got a clinical course coming up. We do one of these a quarter. This one's on sale. So if the March 22nd date works for you, great. We'd love to see you there. That's at awakenasleep.com/events. This handsome doctor is the one who's going to talk to you about all that stuff for the day. To be clear, this is virtual, so you don't fly anywhere. It's our virtual hands-on course. You can bring an assistant. There's no additional charge. You're welcome to do that. If you are looking for help on the business side of things, we have our live Pivot Dental Sleep Medicine Masterclass. This is a workshop level class, so you can bring your team, work on your plan, get a lot out of this. We're going to have 75 seats available for this entire course. And several times throughout 2 days, we're going to break into groups of 25. So you can really talk to these people. If you don't recognize the faces, some of these folks are the highest volume producers in DSM in the whole country. So we're going to have a whole bunch of people there, including the handsome doctor on our webinar tonight. Okay. That's our exciting stuff for tonight. Both of those you can find at awakenasleep.com/events. Both of them are on sale right now. So if you guys are interested, this date, which should be on the slide, September 20th through the 21st in San Diego. I don't think anybody hates September in San Diego. San Diego in September. I don't know how you say that. It's sunny out here. Anyway, we'd love to see you there if you guys want to hang out and talk DSM and do more in your business. Sale ends for that one on the 1st. It's not April Fool's. It's just the end of early bird. Sorry. Okay. That's that's enough of that. We got some more questions, and y'all are still hanging out. So I want to make sure that we get all the questions answered. So I'm going to segue back into that. My Q&A went away. Oh, all right. I've just not been doing this for a long time, guys. I'm sorry.
Where'd
Don't
you just
mock
go on
me.
vacation to?
No, we're not going there. We still have people's actual clinical questions on your webinar.
Let's ask.
Thanks for the plug. Hawaii. I don't have Hawaii brain, I promise.
It sounds like it.
Okay. Next question.
Yeah.
Materials and exercises. You talked about giving morning repositioners that everybody does, and exercises. Can you just tell us briefly what exercises you have patients do in the morning to help with this stuff?
Yeah, there's actually, I'm sure you guys have to have the link too. So whenever I give patients their home care instructions, there is an AADSM link for muscle exercises in the morning. Do you guys have that, Michael? I'll get it for you. But there's a great video that you can share with the patients. But essentially for all of our patients, you know, we want you to slowly kind of stretch your jaw out. And we want to slowly kind of replace it. So, I mean, it depends on the patient and what's going on, but you know, I just have them open slowly as wide as they can, hold it, and then move left and right. And then kind of close down slowly and make sure that you can touch, see, and feel your teeth coming together. And as long as that's good, then they're good to go. So a lot of the patients will, believe it or not, a lot of patients come back, hey, my jaw hurts in the morning. And it's usually when they're using that morning repositioner. So those patients that it's like, all right, put my morning repositioner in and it's starting to hurt. You want to let those patients give them another hour or so before you try that morning repositioner. And let all that kind of calm down on itself, and kind of go from there. Did that answer the question? I don't know that I answered the question there.
That's the plain English is helpful, man.
AADSM has a free link somewhere. It's a video on morning exercises. It's really good, and you can put it in your home care instructions.
Cool. You talked a lot about what formerly like dual purpose appliances, like an oral appliance for treating sleep apnea, but you add an NTI-esque anterior discluder to this appliance, possibly posterior buildups, that kind of thing. So how effective are those dual purpose appliances that you've seen a lot of patients? What percentage of your patients can you treat both those, the early TMD issues and also the oral appliance or the sleep apnea?
Yeah. I mean, I would say, again, 90% of the time, I'm going to say the patient can wear the device and it's not an issue, and we're successful. I would say 80% of the time, probably the patient feels better in that. Maybe they, that other 10%, 20% of the time, they don't feel better, but we're not like worsening anything as well. And we're treating the apnea. So, a very large amount of the time, I really don't have that many patients I can think of offhand that won't wear this because it induces some sort of pain in their jaw joint. I mean, it really it just doesn't happen if you're conservative. You start off in a conservative bite, you move these patients slowly, let them acclimate to these positions, and you reduce and minimize the pressure on their jaw joint. I mean, there's only up that you can go, to be quite frank. And so, I have had a patient say, I can't wear this thing, it hurts. Those are usually the patients with limited openings, limited, protrusions. So,
that you already have a yellow light in the first place.
Yeah.
Cool. All right. We're pushing 10 minutes after. I'd say just can you give us your last like hurrah, like what would you say to your younger self now that you know all that you know from delivering all these cases, treating all these folks? What would you speak to these guys that are possibly less clinically experienced than where you've been, what would you say to them?
Yeah, understand that you can help them have a good foundation of the anatomy and the function of the jaw joint of itself, and understand, that the jaw joint is the most complicated joint in our body, right? So we can oversimplify it. We can certainly overdo it when it comes to trying to figure it out. And so if you really want to know, take some courses on TMJ, help understand that a little bit more, and then know that you can help these patients too. They're going to be wearing a guard either way. I can tell you that. I mean, show me a freaking TMJ dentist that doesn't put their freaking patients in a guard. And so if we can put them in a guard and open up their airway at the same freaking time, why wouldn't we?
Yep.
So, again, we just need to be cognizant that we don't want to do it forcefully and quickly. But we can help decrease the pressures on these things and go from there. So
Cool. I love it,
and
man. I love it.
take it out, if you.
Yeah, I mean, the worst case is you take it out.
Yeah.
I'll end it with, I mean, you guys heard him all night long saying how this is doable for most patients. Positive outcomes for most all of the patients he's delivered like this. I just encourage you guys, hey, we want this to be educational and helpful and practical in your office. Go out there and learn more and do more. These folks need your help. And the TMD specialist is also going to put most patients in a guard, to what he just said. But yeah, go carefully, go slowly.
Yeah.
Keep pushing. Don't go fast and go, wah. But these folks need your help. And we're glad you guys joined us tonight. Thanks so much.
I'm looking at my medical building, and it says this patient has no active TMJ disorder. So I guess it would depend on what you consider active. Does that mean
Yep. Michael Villag, that was for you. Acute or active. Ask your medical biller what they're talking about to make sure that you're in compliance with that. Those are the words. All right, everybody. Thank you much for tonight. We appreciate you all truly. Have a great evening. We'll see you next time.